Okay, welcome back everyone from our short break after the Ryder Kaplan Memorial Lecture. I'd like to now kick off our community engagement session, and I'm going to do that by introducing our moderator for this session, and our moderator is Erika Castellanos, who is a transgender HIV positive activist from Belize, residing in the Netherlands. Ms. Castellanos is the Director of Programs at Global Action for Trans Equality and is alternate board member to the Global Fund to Fight AIDS, Tuberculosis, and Malaria for the Communities Delegation. Thank you so much for being here and moderating this session, and I turn it over to you, Erika. Thank you.
Thank you very much, Robert, and thank you everyone for joining us in Adherence 2020 for our community engagement session. Today we're going to have three amazing panelists who will talk to us about resource allocation, the importance of investment in community HIV response, about community-led research, and communities in humanitarian and emergencies disrupting HIV services. And for this, we're going to start with our first panelist, Ms. Cathy Ferrier, who is going to take us through resource allocation, the importance of investing in community HIV response. Cathy is head of Positive Action Global at ViiV Healthcare and leads the team delivering strategic partnership and grants and donations to community organizations supporting people living with or at risk of HIV. In addition, Cathy is chair of the Circle NGO, founded by Annie Lennox. The Circle works to tackle gender inequality and provide support to disempowered women and girls across the world. Cathy, please go ahead.
Good morning, everyone, and good afternoon, depending on where you are in the world. So my name's Cathy Ferrier, and I'm the head of Positive Action Global at ViiV Healthcare, as Erika said. Good to speak to you again, Erika. So today I'm going to talk about this subject from the perspective of positive action, which is part of ViiV Healthcare that invests in community organizations across the world. So I don't have any PowerPoint, so you have a rest from PowerPoint presentations for a moment. As a lot of you will know, ViiV Healthcare is a company that's 100% committed to HIV, and we're always looking to move beyond the status quo and to find new ways of navigating the challenges of the HIV epidemic. But absolutely core to the mission is putting people living with HIV right at the center of everything we do at ViiV. We established positive action programs some many decades ago, and the funding of positive action programs provides funding streams for projects around the globe that deliver vital benefits to the most vulnerable groups. And we work with those communities most affected by HIV on projects covering education, prevention, care, stigma, and treatment-related activities. My own background is in broader international development, and I learned many years ago of the importance of listening to those most affected by the issues that you're seeking to address. It's an absolute fundamental to achieving successful and sustainable change. And it's only when the communities and people directly affected have a voice and are at the center of the decision making can you direct the resources that you may be able to bring to bear most effectively. And that's what we seek to do at Positive Action. It has been abundantly clear this year with all of the additional challenges that COVID-19 has brought, that it is the community groups and organizations that have been able to respond to the new challenges facing people living with HIV. And as we know, when health systems are under strain and are redirected towards a new pandemic, communities remain focused on ensuring a continuity of service and adapting approaches to meet the challenges. But as we all know, the communities most affected are often under-resourced and face many barriers. At Positive Action, we try to work across many key populations experiencing marginalization, stigmatization, discrimination, and even criminalization because of their sexual orientation, their gender identity, or specific behaviors. And they're at considerably higher risk of HIV infections compared to the wider general population. Among gay men and other men who have sex with men, as well as people who inject drugs, the risks are 26 and 29 times higher, respectively. And for sex workers and transgender people, the risks are 30 and 13% greater, respectively. So the concerning levels of vulnerability for these need to direct resources to those underserved populations and accelerate and scale up efforts in HIV prevention that are evidence-based and informed by the lives of both key and priority populations. We must focus on promoting awareness of the need for stronger community-led systems and promoting the delivery of integrated, people-centered healthcare, and communicate the need for continued investments in HIV service delivery models that emphasize community-based services, client autonomy, and self-care. To achieve the goals of ending the epidemic, we must work to end health-related stigma and discrimination associated with infectious diseases, including HIV. And the role that people living with HIV, advocacy groups, and communities play in addressing the local HIV response to end stigma and discrimination is absolutely vital. I mean, both HIV and COVID-19 have, as we all know, disproportionately impacted local marginalised communities. At ViV Healthcare, we actively collaborate with partners across the public, private and not-for-profit sectors to meaningfully engage with key and priority populations who are at the greatest risk and the most vulnerable to HIV infection. But the things that we struggle with are how to ensure the resources are really well directed and they meet the needs of people living with HIV and those groups most at risk of and it's a constant challenge that we face. And at Positive Action, we've built strong relationships with community organisations and continue to have open dialogue with community organisations and people living with HIV to better understand the gaps in service and the support that we need to provide. Some of you may be familiar with the funding of Positive Action, but in our allocations, we endeavour to provide a variety of different funding levels. So for smaller grants to support innovation to the larger grants aimed at supporting scale up of evidence-based and proven interventions. And in addition to that, we look to support different key populations with targeted funds and resources to build the capacity of the communities themselves to respond. From our own experience, the demand for financial support from communities is far in excess of the available resources that we have to bring to bear. And so we work very hard to create more strategic partnerships that, when combined, can generate key strategic gains in the fight against the epidemic, pooling resources to achieve greater impact. We work in partnership with all stakeholders and communities in order to focus on key affected populations, focus on most impacted geographies, and support priority interventions. And by working in conjunction with key stakeholders, we can achieve better outcomes for people impacted by the disease through expertise sharing, synergy in partnership, innovation, and ensuring that the care provided really supports the needs of these key and important priority populations. So whilst we know tremendous progress has been made in the past 30 years, the HIV landscape is constantly changing, and we are using our heritage and expertise to refine our approach and map an HIV-free future, leaving no patient behind. And we continue to evolve our approach to supporting communities. And whilst we have and do enjoy great partnerships in many parts of the world, we know we must remain open to new partnerships and new approaches. So just to finish, obviously 2020 has been an extremely challenging year for all of us, and we do need to redouble our efforts. More than ever, though, we do need communities and people living with HIV to be able to access the resources they need, because fundamentally they play a pivotal and critical role in the HIV response. So from my perspective, investing in communities, identifying ways in which communities can really make meaningful differences to people living with HIV, keeping people living with HIV right at the centre of all our decision making is absolutely critical to positive action and indeed to ViiV Healthcare too. And with that, I'm going to hand back to Erika.
Thank you very much, Katie, and thank you for that insight on community investment and believing in community. And thank you very much to you and Positive Action for all you do in supporting communities. And from the investment and community, we move to another very important topic, something that we always ask for and demand, which is community-led research. We demand its inclusion, its recognition. And we're going to have Dr. Asa Radix talking to us about the role of communities in successful biomedical HIV research. Dr. Radix is the Senior Director of Research and Education at the Colin Lord Community Health Center in New York and a Clinical Associate Professor of Medicine at New York University. Dr. Radix has over 20 years of experience providing care to trans and gender diverse populations. Dr. Radix's research focuses on transgender health and HIV prevention. He is currently co-chair of the World Professional Association of Transgender Health Standards of Care 8th Revision Committee. Dr. Asa Radix, please.
Thank you so much for the introduction, Erika. I hope my slides are up and that you can see them. And I'm very happy that I was asked to talk about this, and I hope everyone is staying safe at home during this difficult time. So, I wanted to, I do have a PowerPoint presentation. I wanted really to think about, what is community-led research and why it's important for HIV biomedical research. How should partnerships be developed? What are the roles of researchers and community stakeholders? And what are the types of issues that need to be addressed at the beginning of these partnerships? So, first I want to say, language really matters. When I looked at the literature, I found that people were using so many different terms to kind of convey the principle of community engaged research, from community-led research, community-based research, community-informed, community-engaged, and a subset of that, which is community-based participatory research or practice. I think it's really, as someone who's works in a clinic embedded within the community, that community-led research doesn't just mean research that's done in community settings or community-based interventions. And it certainly doesn't mean, well, we had a cab, so we've done our job as far as community engagement. Community engagement isn't just checking a box, right? It's not just window dressing on a study. I want to just use this definition of community engaged research, which is the process of working collaboratively with and through groups of people affiliated by a geographic proximity, special interest, or similar situations to address issues affecting the well-being of those people. So basically, working with community, throughout the research process. I think it's also important to understand there are many different types of stakeholders. In addition to, the community stakeholders, you're also dealing with, broader levels of stakeholders, NGOs, local policymakers, medical professionals. You have national stakeholders that are involved, ministries of health and national NGOs, as well as the global stakeholders like WHO and UNAIDS. And I think this is especially important in, HIV biomedical research, where there's so much money involved and everyone wants a seat at the table. The other point is that there are many different aspects of community participation. It's on a spectrum. So, anything from being involved in solely an advisory role, all the way to true community-led and controlled research, where the community really defines these issues, research questions, creates data collection tools, helps with recruitment, or actually defines the recruitment, does data collection, analyzes data. So obviously, we are looking for the greatest community engagement possible, and I'll be showing you that, unfortunately, that doesn't always happen. We have frameworks that, describe the differences between, the traditional way of conducting research, community engaged research. And as I said, a subset of that, which is true community directed research, community-based participatory research. When we think about the traditional way of doing research, which has been driven by researchers, usually academic researchers who, find themselves in a community that they don't have ties to, where they conduct, all aspects of the process, from the selection of the research topic all the way through to dissemination. That really has been a traditional model. And I think now we're seeing much more where community is engaged in identifying relevant issues to the community, that they are ensuring acceptability of the study design. They are, truly being involved and consulted on strategies for recruitment and retention, and adopting appropriate instruments, being involved in data collection, also deciding really where the results should be, who the results should be shared with. Obviously, in the community, but wider dissemination as well. Most of my work has been in transgender communities. So I wanted to talk a little bit about some of the issues around conducting research in communities of trans and gender diverse people. So, I wanted to start with basically saying that, we do have a lot of data gaps for almost all low and middle income countries. But, we do know, for example, we estimate about 25 million transgender adults worldwide. Also, that we see an estimated global HIV prevalence, which is extremely high, around 19% among transgender women. Also, that transgender women are approximately 49 times more likely to be living with HIV. And also within, different populations, for example, transgender women who trade sex, that the risk of HIV is much, much higher. And also understanding that transgender people are not siloed within, a gender identity, but also are spread out to many other populations that are known to have higher risk for HIV. For example, higher rates of transgender women being incarcerated, the fact that, as I said, many women trade sex, the issues of transgender men and non-inclusion of research are really problematic. We know that many transgender men have sex with cisgender men. Many transgender men identify as gay or bi. And of course, there are the issues of folks who are also involved in using injection drugs. So when we think about research in trans populations, it really does need to be quite broad. Also in the US, we see very high rates of HIV among trans people, but I think here we also can see the disparities by race and ethnicity. So whereas in the US, the HIV prevalence is less than 0.4%, we see for transgender women, it's 14%, but among Black transgender women as high as 44%. And the rates in transgender men are definitely high enough to make this a priority population for HIV, research. So we see here prevalence of about 3.2%. So, as I, showed these numbers, I really wanted to reflect about the fact that although the rates of HIV are so much higher, that trans people are really not engaged appropriately in research. And I think there are many reasons for this underrepresentation. There are many barriers to engagement, including being, unaware of clinical trials, being worried about side effects, especially in vaccine trials, drug intervention studies, worry about the impact on hormone levels, as well as high levels of medical mistrust as a consequence of past or anticipated discrimination in clinical settings. We also need to think about, travel, transportation, time issues as reasons why people aren't engaged in research, and thinking about things that increase participation in research. For example, when the research is a community priority, or when the study is inclusive of trans people, and when the research team includes trans-identified staff and a welcoming and inclusive facility that's doing the research. And, also thinking about structural issues like the forms that are created, and do they allow people to really reflect their gender identity? Issues of having appropriate identification, and all of the structural issues that impact on participation, whether it's, housing, employment, and of course, understanding that people expect to be compensated appropriately for participation in research studies. So I wanted just to think about some of the benefits of community engagement for researchers. Obviously, it helps identify community priorities. Input into study design helps to make tools and interventions culturally appropriate. And also, having community engagement builds trust. I think that's, we should say it twice, but it builds trust between researchers and communities and fosters, future collaborations. Communication is key. So improving communication, addressing community concerns, obviously beneficial impacts on participation and retention, and also, more appropriate and wider dissemination of results to communities. And I think we all know what can happen when, community engagement doesn't happen. And this is a picture of, protests at the, International AIDS Conference that was in Bangkok in 2004. And these are protests against the early PrEP trials. And really, the underlying cause was, the lack of community involvement at all stages of the research. It showed the power of advocacy on the part of, communities, and it really emphasized the importance of transparent communication. And what are the benefits for community stakeholders? Obviously, it gives people an opportunity to think about important disparities in the community and how to address them. And, having a role to ensure that the community conducted is culturally relevant. There are other positives too, that it can create and protect jobs. It builds, if done properly, builds research infrastructure. It reduces the power imbalance, which is always going to exist when much of the research in HIV is happening in communities that have been marginalized. Identifying risk associated with participation and thinking about ways to protect participants, addressing these ethical, political, and logistical concerns. And also that, with appropriate community engagement, research is more likely to lead to improvements in community health. There are many, there's a lot of guidance on how to build authentic community research partnerships. And I think, it's important to think about issues of respect, mutual understanding, transparency, accountability, integrity, and community stakeholder accountability. For community stakeholders, I would say, think about who you're doing your research with. Who are these researchers? Can you work with them? Have they previously worked within the communities? Is there a commitment or experience to community engagement? What is your level of participation going to be? Are you going to be sidelined to participating in a cab once a year where you're just shown the material that's happened and that's it? And how is it going to benefit you? How are you going to be compensated? This is not volunteer work. Do you have the bandwidth? And what are the resources that are needed? What about the research burden on our community? Especially for folks of trans experience, there is so much, there's money now to do the research in trans communities. So now, I am in New York, there must be at least 20 studies going on. which can be really burdensome, I think. You know, how are people providing input, and how can we maintain commitment? I think for researchers, there are other considerations. You know, why do you think your research is aligned with community needs, and what are your research interests? And for me, when I work with researchers, I say, you know, why are you doing this work? You know, what is your stake in this? And what experience have you had working with community stakeholders? How will the community be involved in the study design, recruitment, publications, and who's going to be, you know, are people going to be listed as co-authors? You know, it's interesting. I've read quite a lot of, you know, the literature in HIV, you know, biomedical research that say they have community engagement. When you look at the authorship, you know, it's rare to actually have the community people involved at that level. How do you cope with the realities of working with community stakeholders, like conflicts of commitment, institutional capacity, community research expertise, which may be very low when you're in an area where studies haven't happened before? And are you committed to capacity building and sustainability? And how will you value community contributions? And have you shown that in how you've allocated your budget? And how have you allocated also for, you know, community advisory board development and management? So again, I think these are all things that have to be decided really early on. You know, it's important to understand how much stakeholders want to be involved. You know, again, whether it's at the beginning when you're thinking about the research question, the design, whether it's in collection, analysis, or dissemination, you know, many different areas. I think it's also important to think about advisory mechanisms. You know, is it through stakeholder meetings? Are you having, again, a community advisory board? Are there advisory groups? How often are people going to meet? And you know, is it going to be at all stages of the process, as we've stated before? You know, I think it's important also to say that, you know, this is something we are aiming for. You know, unfortunately, when we look at, you know, the biomedical research, and this was a systematic review looking at how and where the community is engaged throughout the process. And you can see here that, you know, rarely are they actually being involved in designing the research question, and more often they're brought on board when it comes to things like, you know, looking at the protocol, often not being involved in design of the protocol, but looking at it, and in recruitment, but not being involved in the many other aspects of you know, the process, which I think really is a pity, because, you know, community have a lot to add to the studies. You know, there are many different cultures and priorities. You can expect difficulty, right? You should anticipate and address the power imbalances, and understand that there are going to be trust issues, especially in communities that have faced high levels of discrimination. You know, you need to work on buy-in at all levels and anticipate training needs. If you want people to be involved at all levels, then you need to be prepared to explain and teach people about research. We all speak different languages, and it's definitely so when you're thinking about researchers and community people. And again, you know, transparency in the budget is really important. I wanted to talk about one of the studies that, you know, I'm currently involved in at my clinic, which is the Legacy study. It's a transgender cohort study of gender affirmation, HIV-related health. And really the aim is to evaluate medical gender affirmation delivered in primary care as an intervention to reduce disparities in HIV-related outcomes. And it is truly the first community-based cohort of trans people. And we have about 4,500 transgender adults, 18 and up, across 2 clinics. So Castellan North, where I work, and the Fenway Health. And, you know, again, it's looking at gender affirmation, HIV viral suppression, PrEP uptake, STIs, and HIV incidence. So, you know, again, it's community-based, community-informed research. We started with focus groups at the very beginning to identify research priorities and concerns with study design. You know, there's a community advisory board and stakeholder advisory boards that are fully compensated, and meet regularly, and a research team that's predominantly, if not almost all, trans and gender diverse. Now, the focus groups, we ask people, again, from all steps: study design, sampling, recruitment, screening, study implementation, survey measures, and discrimination, really to think about how this study would go forward. Importance of representation was key. So some quotes: in terms of research priorities of being in research studies, I feel like it's a priority to have trans people, and not just one token trans person, but trans people as an integral part of the research team, designing it from the beginning. I've done a few research things, and sometimes something I always appreciate is when they're run by trans people. Importance of recruitment, needing to be inclusive of patients and participants who are questioning or who do not identify as trans. I think maybe questioning folks may also not feel like they're included under the study premises, even if they would be. Issues of study implementation, so thinking about really about informed consent. So one informed consent process is specific to the use of biospecimens and separate from survey-related informed consent process. At the very least, say, we will come back to you and ask for that specific consent, to say this is specifically what we're going to do, instead of being like, take my DNA. Survey measures, people talked a lot about the fact that a lot of the research in trans communities has been around disparities and deficits, and that they wanted measures of resiliency. So, there's like a scale for depression. I fill out this thing when I come in to my PCP, primary care provider. There's no inverse of that. You know what I mean? There's no elation. So thinking about, again, how we could integrate that into the study. And then around dissemination, and how important it is. People put in all these informations, and at the same time, you almost feel like it never reaches like people, so they can see us in a different light. So I feel like maybe one of the reasons why they don't want to participate. And another person, you're left wondering, what were the results of that study that, they've taken the time to participate in? So I want to say, like, the final message, early and diversified stakeholder engagement is really key to advancing HIV biomedical research. And it's important to engage multiple stakeholders very early on. Engagement can be complicated. And honestly, conflicts during research are inevitable. But there are so many rewards for engaging communities, in that you'll get better quality data, you build longer term relationships, and truly generate data for real change. And I'd like to acknowledge a few folks who helped me think through this presentation. So thank you all.
Thank you very much, Dr. Radix, for such an amazing presentation, who has given us wide education on community-led research, informing us in individual and structural factors that impact trans people's engagement in research. That is great knowledge, but also the benefits of community engagement for researchers and for community stakeholders. I think if there's one thing that I loved about your presentation, is having those written down and outlined, and possibly something that we should send out to all researchers all over the world. So thank you, and thank you also for the amazing work you're doing in the legacy study. I'm very eager to read on the results when they become available. Thank you very much. And we continue with our great panelists today. Our next panelist is Ann Torres. Ann will be talking to us about community as pathfinders in humanitarian emergencies, disrupting HIV services. Ann Torres is a lawyer and former professor of law from the Universidad Católica Andrés Bello in Caracas, Venezuela, and holds a Master in International Law and Health from Indiana University, and a Master's in Gender, Women's Rights and Health from the University of Toronto. ICASO is co-leading efforts to address the health crisis in Venezuela and neighboring countries, in particular supporting Venezuelan NGOs to document the crisis. ICASO has released several reports documenting the complex humanitarian emergency in the country and its intersections with human rights, HIV, TB, and malaria, and migration. Also, ICASA was instrumental in the successful advocacy that pushed the Global Fund to fight AIDS, tuberculosis, and malaria to agree with an exceptional request to provide funding to respond to the health and economic crisis in Venezuela, in line with the board-approved approach to non-eligible countries in crisis. Thank you very much. And Marianne, please go ahead.
Good morning, everybody. Thank you, Erika, for the intro and your kind words, and to the organizer for inviting ICASO. I will attempt to summarize a very complex situation in a short presentation. I will be speaking about the complex humanitarian emergency in Venezuela, presenting some key indicators that tell the story of everyday Venezuelans. And I will also talk about the leadership role of civil society organizations and the results to date that in no way represent the comprehensive response we need. Let me start by describing the complex humanitarian emergency in Venezuela and the health crisis within. I will then illustrate how the emergency has impacted the AIDS response. And I will then highlight a few examples of how the leadership and resilience of civil society, communities, and people living with HIV has improved the lives of thousands of people in Venezuela. And I will end up by providing key recommendations and thanking our partners. Despite having the largest oil reserves in the world and one of the largest gold and coltan deposits, and being one of the wealthiest countries in the Americas 15 years ago, Venezuela is confronting a complex humanitarian emergency. Besides high level of malnutrition as reported by the FAO a few months back, around 6.8 million people, and escalating poverty. In 2018, which is the last data that we have, 87% of households were in poverty and 61.2% in extreme poverty. The health system has also collapsed. This is an atypical crisis that has not been driven by armed conflict or natural disaster. It is a result of political tensions and implosion of the economy with hyperinflation, severe shortages of basic items, including food and medicine, and very high level of corruption, violence, and crime. Despite this, the Venezuelan government denies the existence of a crisis and rejects most humanitarian assistance. But let's be clear, the humanitarian disaster, as the president of the Security Council said a few months ago, started well before COVID-19, and it was not caused by the sanctions imposed on corrupt government officials charged with human rights violation and other crimes. In October 2020, ACAPS, originally known as the Assessment Capacity Project, updated his analysis, showing the degree and complexity of the crisis in Venezuela. The reason to show this slide is twofold. First, to emphasize that the humanitarian crisis in Venezuela is real and is official, and it is recognized by the United Nations. And second is to show that of the totality humanitarian projects supported by OCHA in the country, 68% are managed by NGOs, highlighting once again the important role of this sector in humanitarian emergencies and responses. More on this later. For the last 4 years, we have seen an increase in shortages and stockout of most medication, from aspirin to morphine, antiretrovirals, and antibiotics. Now, let me pause here for a moment. The fact that the data we are getting from the government is not reliable or doesn't exist makes our social monitoring, which I will explain later, even more relevant and important, highlighting the role of civil society as watchdogs. I will go into some details in a few minutes, but let me emphasize that the government has not published epidemiological epidemiological data since 2016. The provision of drugs and strategic supplies for health programs is one of the country's biggest challenges. There is a critical stockout of essential drugs for HIV and other sexually transmitted infections, opportunistic infection, preventing congenital syphilis and malaria treatment. There are also no diagnostic and monitoring tests, insufficient reagents and supply for labs and blood banks, and insufficient vector control supply, such as nets, insecticides, and supporting equipment for malaria. This is due to a number of factors, including lack of funding, fragmented supply management, lack of domestic pharmaceutical suppliers, insufficient internal controls in managing the distribution of drugs, and the illegal drug market, which has exacerbated the stockouts. Additionally, more than 22,000 doctors have fled Venezuela, representing 65% of HIV specialists. Maternal mortality is widely accepted as a key indicator of health and socioeconomic development. This slide shows the increase in maternal mortality rate in Venezuela. The red line is based on official government data. And it also shows the last year the government published information, which was 2016, that resulted in the firing of the Ministry of Health. You can see a rapid increase between 2014 and 2016, and what experts have estimated for 2017, 2018, and 2019. The HIV crisis is not independent from the overall humanitarian emergency or the crisis of the health sector. What is perhaps different is the role of those affected, people living with HIV and their families, organizations, and networks, in responding to the crisis. I will discuss the resilience of civil society in a few minutes. Based on official data shared by the National AIDS Program, which is not published, in 2018, there were 4,000 new infections, of which 26% were women. In 2019, while no total number of infections was presented, 46% of new infections were on women. This graphic shows a steady increase on the number of people living with HIV. And alarmingly, as reported by UNAIDS, during the same period, a 7% viral suppression rate. In this graphic, we can see a steady decline of availability of ARVs between 2012 and 2018, with the critical point in 2018, where our community monitoring initiative was able to document a stockout of 84% of ARVs. Our partners have been raising the alarm since 2015, writing to the United Nations and the Global Fund for support. Finally, the Global Fund accepted our petition and provided emergency funding for 2019 and 2020 and 2021. The first $5 million were used to purchase TLD in 2019, and this is the rebound that you can see after 2018. Now, availability of ARV is only one aspect of the HIV crisis. There is no diagnostics, no viral load test, no CD4, no treatment for opportunistic infections or condoms. Women living with HIV are forced to deliver their babies. No C-section is offered, and no treatment is available for them or their babies. Additionally, no baby formula is available. The data presented here was presented by the National AIDS Program at the end of 2019. This is the total at national level of new cases disaggregated by age. The National AIDS Program is reporting a 10-fold increase of the total new cases of HIV in children in 1 year. This is a clear indication that our health system is really in shambles. To guide humanitarian assistance action to 4.5 million vulnerable Venezuelans, as calculated by the UN, the plan takes into account intervention related to COVID, which is important. And the plan takes into account the 120,000 people living with HIV identifying the master plan and considers them as prioritized population group. This is based on the advocacy that our civil society partners have been doing. They are considered a prioritized population group because of the risks and the protection that they need, requiring a specific protection through identification, quality services and support, and strengthening community protection. So let me talk about what civil society has done. I divided their actions in 3 parts, which are all related among themselves. In regards to community service delivery, communities continue to respond despite COVID-19. From HIV prevention to treatment to care, community groups in Venezuela have been at the forefront of providing this to people living with HIV. For example, the only condoms that arrived in the country in 2018 and 2019 were procured and distributed by community groups. At the end of 2019, 20,000 diagnostic tests were procured and are currently being distributed by civil society. These are the only diagnostic tests available in the country. Millions of dollars on ARVs and treatment for opportunistic infection have been procured and distributed by civil society and community organizations. The RVG, which is the network of people living with HIV, currently has a program of navigators to ensure linkages to care and treatment for people living with HIV. This to increase adherence. The navigators go to HIV care and treatment services where they interview people living with HIV and provide guidance and advice in different aspects related to their personal situation, health condition, and HIV, among others. And despite the severe mobility restriction and with support from community organizations, 100% of the HIV consultation, ARV pharmacists, and health personnel continue to provide care for people living with HIV, with an emphasis on emergency cases and according to the restrictions imposed at national, state, and city levels. And this is key because within the humanitarian emergency where services are not available, HIV services are working just because civil society is there pressuring that. So the second aspect of community action is community-led monitoring. Civil society has been systematically documenting the parallel and concurrent crises. In particular, I would like to mention the work civil society in the HIV field has been doing, led by the network of people living with HIV. So the question is, why monitor? And we decided to monitor how people were accessing services. We were getting information from the government and some of the UN agencies when the shipment of drugs arrived in Venezuela. But then we didn't know what happened then. So we created a project with support from several donors that look at people accessing treatment at pharmacy level. So we are able to monitor from the purchase of the treatment, normally by the Pan American Health Organization, to the shipment to Venezuela, to how it gets to the central warehouse, how it gets to the regional warehouse, how it gets to the pharmacies, and then how people access that. So our civil society partners have been able to monitor and document almost in real time the availability or lack thereof of ARVs in the government pharmacies. This data collected through a robust method and a comprehensive mechanism has been used, among other platforms, to convince the UN system and the Global Fund of the situation of Venezuela. $17 million have been secured to purchase ARVs and limited quantities of anti-TB and anti-malaria medication, plus very limited viral load test reagents from the Global Fund. The same method that was created to monitor the availability of ARV is being used to monitor the availability of personal protection equipment to respond to COVID. So let me go to the final section of the presentation. The system, which is the community-led advocacy. The systematic documentation mentioned above has served to advocate with reliable and credible data for the international community to invest in solutions to the crisis. So let me focus on two key results. First, the decision of the Global Fund to approve funding to address the health crisis in Venezuela for a total of 17 million, 5 million in 2019, 6 million in 2020, and 6 million for 2021. These amounts also support efforts by civil society to monitor the implementation and use of these resources. But $17 million for 3 diseases is by no measure enough. Based on recent calculation, containing what is known as the master plan, which was developed by a multi-stakeholder group in 2018 and revised in 2019 and 2020, the need is around $130 million. Of course, this is a very conservative estimate when you consider the situation of the health and other infrastructure in Venezuela, like transportation. Additionally, these estimates are based on needs assessment using mostly government data that at the very best is unreliable. Let me also mention that the Global Fund has decided that Venezuela is now eligible for the malaria component due to the resurgence of the disease. And while we may celebrate this, it is also sad for Venezuelans to affect the fact that our malaria response, the best in the region 30 years ago, is in shambles, and assists the whole health system and the country in general. It is important to recognize that this achievement is the result of the joint work of people living with HIV who are part of the Venezuelan Positive People Network, which is the RBG, and other organizations, doctors and other health workers, the Venezuelan Society of Infectious Diseases, PAHO, and UNAIDS. The responsibility and commitment to the people most in need and the networking done by civil society allow us to respond strategically to overcome the wave of criminalization that was unleashed against the work of the monitors and navigators in Venezuela, as well as the constant refusal that limited access to public information on the management of HIV services. It is important to highlight that with a modest and intelligent investment and in a short time, the Global Fund is saving the life of 40,923 people living with HIV. This investment is a direct result of joint, evidence-based advocacy by civil society. How do we know there are 40,923 people with HIV accessing TLD between January and July? Because we counted them. So I have focused on the TLD, which is what is being purchased with the money from the Global Fund. But this is the shortage of non-TLD ARVs with average around 64% between January and July 2020. From New York to Geneva, through Washington, Amsterdam, Bogota, Mexico, and Paris, and of course in Venezuela, our partners have met with global and regional leaders, have spoken at conference, UN meetings, including the UNHCCB, to denounce and condemn the lack of government action and the unresponsiveness to the health crisis. The data collected and analyzed has been used in these different settings to advocate for attention to the situation in Venezuela. Some have done it openly, others have preferred to remain underground for fear of persecution by the government. As I said before, Venezuela is confronting a well-documented, complex man-made humanitarian emergency, made worse by a deepening social and economic debacle, including that there is no cash or gas, there is a currency freeze, record high inflation, food insecurity of millions, a health system that is destroyed, massive migration, including of doctors and other health personnel, stock out on medication, and now COVID. All this in an environment of political disarray, disregard for human life, high levels of violence, and daily gross violation of human rights, including of our partners in the country. However, these community partners continue to play their roles, ensuring access to treatment by avoiding treatment interruption, ensuring people living with HIV have food on the table, securing personal protection equipment for those working on HIV, and of course, documenting, advocating, and denouncing. In conclusion, the gains that we have made with HIV, even those recent, are at risk to be lost, and now we have increased the risk of multiple epidemics, including an even bleaker situation for malaria. It is important that we address structural issues, including support communities on the ground, an effective system for rapid international support for community responses in crisis situations. The key we need support for. We need to have an international system to build and support local skills for supply chain and risk management. We also need an international system for emergency support that goes beyond the work of the Red Cross and Doctors Without Borders, the work that they are doing saving lives. And finally, we need better and more effective intersecting and transdisciplinary responses that bring together, in the case of Venezuela, COVID, malaria, HIV, nutrition and physical well-being, migrant prisoners, TB, human rights, key population. Also, we need to remain vigilant of human rights and how governments are using this crisis to continue violating our basic rights. So the first step is to create a mechanism that is well-resourced, not only with capacity and skills, but also with financial resources that can support communities in emergency situations. Let me finish by acknowledging our in-country partners, in particular ACSI and the RBG, for their commitment for a better Venezuela. Let me also thank our partners and our donors. Thank you.
Thank you very much, Marianne, for that information. Indeed, it's a very sad and very worrisome situation our peers are going through in Venezuela. But at the same time, it is admirable what communities have been able to achieve amidst this crisis. I mean, I remember a couple years ago when we started hearing about the crisis in Venezuela. We need to say it bluntly, the world was silent. There was so little response, but now we're seeing that response coming through, and it's because of the efforts of community. And I sincerely want to express my gratitude for what you, ICASO, and the country partners have been doing to really bring the voice of the Venezuelan people and the needs at a global level. So let's keep it up. We have gonna open now for questions and discussions, and we already have a few questions for all of you. Please, this is a discussion with us. Let's have it like a friendly discussion. I might ask a question to one of you, but if you have also some input, please feel free to jump ahead. And Cathy, the first question is about, you mentioned positive action is funding key populations. Can you share how did positive action arrive to the decision on investing in key populations?
Yeah, sure. So as you know, Positive Action has been operating for a number of years now. And what we try to do is to, in consultation with community partners, we try and make sure that we spread some resources around to where we feel there is greatest need, and we have a commitment to leaving nobody behind. So even if the numbers and the burden may be sitting in sub-Saharan Africa, we also make sure that we provide funds for other parts of the world. So we're looking at geographic focus, and we're also looking at key populations that are most at risk. So for instance, we have a focus currently. We're doing a lot of work on harm reduction, to see where it would be, where those resources could be focused, whether it's a geographic focus or whether it is a specific population that we might want to support. So it's an iterative process. We have a strategic advisory council that advises us. We also have review committees that are from the communities that we work with, and they look at any of the funding rounds that we put out there. So it is really around trying to gather a lot of information from civil society to understand where we can best move resources and mobilize and strengthen civil society response.
Thank you very much, Katie. Marianne, in the context of the health crisis that you presented to us, that it's like a nightmare in front of my eyes when I saw the presentation. How has community been able to continue doing their crucial role in monitoring and advocacy, given everything that is happening?
That's an interesting question. I think it's because they have to. If they don't do it, they die. You know, if they don't get the treatment that they need, they die. And I think, you know, reflecting in the previous presentation is that, you know, it's not only about community-led research to obtain data that is usable and important and relevant, but it's also, you know, this community-led monitoring. They are collecting the data that they need to survive. They collect the data, for example, to call attention to a pharmacy in a specific city that ran out of TLD. And how do we then mobilize with the Ministry of Health or the Nationalist Program, the UN partners, to make sure that next week that won't happen, or that situation is addressed. You know, and it's not like it works perfectly, but having people on the ground, people that understand the system, people that are trusted by the people that go to the clinic or to the pharmacy to pick up the ARVs. So that's, you know, like having that person there, that all the monitors and all the navigators are people living with HIV. And I think that's part of, you know, how key this project is. And, you know, I think it goes beyond a project, really. It's now like a way of life. And they have become, and we have become more a professional, if I can use that word, in the tools that we are using, and making sure that the data is exact, that we are not, you know, counting twice a specific population, that we, you know, that we are getting the data not only from, you know, our UN partners, but also from the people that are picking up their medication from the pharmacies.
Thank you very much, Marianne. And, you know, talking about the situation in Venezuela, the community involvement, their resiliency, their huge need, and that gap need that hasn't been met. I would like to hear from Dr. Asa Radix and from Cathy. You know, Dr. Asa Radix, I'm not sure if, you know, the presentations you mentioned about community-led research and those involvement, how would that play out in a situation like we have in Venezuela? And is it even possible? And then, Katie, can you mention a little bit about how can we make the donor community more involved in providing for the people in Venezuela?
Yes, you know, I think it is a really difficult question, you know, understanding what is going on in Venezuela, but I think in any country where there are major disruptions to, you know, medical services, clinical services, and so on, and obviously research, you know, I think the issue is that whoever's doing the research needs to be aware about how the environment is impacting participants. And really the only way to do that is to have robust community engagement. So, you know, it's probably even more necessary in these situations. And again, you know, engagement, as you saw, involves many different ways to be in touch with communities. So, you know, if there's no phone service, then perhaps you're going to have more face-to-face meetings. If there's difficulty, you know, again, with internet and things like that, you have to move to other ways of meeting. And now with COVID, you know, we're not meeting in person so much. So there's even more a layer. But definitely, I think in these situations, more communication is important to understand what is going on. I'll have to say that I'm in New York right now, and we were really the epicenter in the US for COVID in March. And, all of our studies essentially stopped, right? Because participants couldn't come into, they couldn't come into our clinic, which is the site for a lot of our research. And, we had to pivot very rapidly to doing things, remotely, having people do, online surveys or home test kits and things like that. But again, I think, that is incredibly difficult if you're also dealing with, the massive interruptions similar to, what has been happening in Venezuela. Thank you.
Thank you.
I'll try and answer your question, but possibly not from an HIV lens, but from more of the broader humanitarian lens. I think what we've just heard from Marianne really points to the fact that a strong civil society is absolutely vital, and it can't be built once you're in a humanitarian crisis. It has to be built. So the investment that needs to go into strengthening civil society across the globe is important all the time. And from my own experience of working, as I say, in the kind of broader international development sector, when humanitarian crises emerge, it's the civil society that you have to go to find out what people actually need. And the big INGOs have those relationships and have built those relationships. It's absolutely vital to have them. And I think that is this really points to the fact that investing in civil society throughout whichever area of development you're working in is absolutely vital. You will need to call on those people. They will be the people that will tell you what it is that's needed. So investment in building, capacity building, civil society organizations on the ground, communities, to be able to speak out it just highlights just how important that is when things are as complicated and as Marianne kind of outlined in her presentation.
Thank you very much, Keita. And I'm going to go to Dr. Radix now. So in your presentation, Doctor, you talked about the participation continuum and you shared the different levels of engagement. I wonder if you can share with us a bit about what are some of the barriers to optimal engagement and what is needed to break those barriers.
Yes, I mean, I would say the primary barrier is really not on the side of community. I think that the primary barrier is really with the investigators about understanding the need for participation at every level. I mean, I was asked once by an investigator who said, I don't see why I should be, engaging community like at the stage of the research question. I don't have funding yet, so many proposals don't end up being funded. So why should I involve people? So really what they want to do is, check the box and just have the community advisory board just to say that they have community involvement. But I would say that, it really is so important for that first stage to happen, that you sit down with community, embed yourself within the community, before you even think of the question, what you're researching shouldn't be solely around what's being funded at the moment, or how I'm going to make my career or how I'm going to get my faculty advancement. And so I would say, unfortunately, as I said, there is a little bit of a power imbalance. And it really is for the investigators to do that first outreach in many cases. I mean, of course, you do have situations where, community members decide on the research question on their own, and they're the ones who do the outreach to find people, scientists who can assist with getting funding and who can assist with, maybe some of the issues of the study that they're less familiar with. Maybe it's the methodology, maybe it's the analysis. But that tends unfortunately, that tends to be less seen.
Yes, and we have a few minutes left, but there is another question for you, Dr. Radix. So it's so common to have check-the-box methods for community engagement. How would you suggest implementer move past this? And how do we make more involved community engagement a priority for research funders?
Yeah, I think, this is such a good question. I think, investigators, especially being aware of the benefits. I think once you've gone down the road of true community engagement, even though it's difficult to start with, you'll find that it so transforms the way that you do research, and so transforms the way the research is, again, embedded in the community, accepted by the community, that you will never think about doing it any other way again. I think that the issue is that people aren't aware that there's a different paradigm. There's a different way of doing this work. So, I would just suggest that both communities and investigators, and understanding that there are many people who have a foot in both sides, really, look at best case examples and get educated about doing this.
Thank you very much. And before we go, Marianne, quickly, what can you tell us the main message? We have a huge audience in Adherence 2020. We need them to tell them what can be done about addressing the humanitarian crisis in Venezuela. The floor is yours.
Wow, Erika, I wish I had an answer for you that is that clear as your question. If I may reflect on something that the doctor said before about best practices, I think, like for us in Venezuela is about, what is the role of civil society and how do you make sure that you are documenting the value of civil society and what civil society is bringing to the table. Katie said, like civil society is the one that is responding. In any humanitarian crisis, civil society is always the first to respond. Why? Because, well, they already are in the ground. They already know the needs. So for me, is the investment in civil society to continue doing what they are doing, monitoring, advocating, protection of human rights, making sure that they have the tools and the financial backing to be able to respond in a more systematic way, and at the same time document what they are doing so they can show the value that they have and the value that they are providing.
Thank you very much, Marianne. And I really want to thank all our presenters today, Dr. Asa, Katie, Marianne, for those amazing presentations and the words about community involvement, putting people at the center, community in the forefront. It was very educational, extremely interesting, and we can be here for a whole day having this conversation. Unfortunately, our time is up. I hope all our viewers have enjoyed us so much. We want to let you know we have enjoyed being here with you, and we hope that you continue enjoying Adherence 2020. I want to remind our viewers that we're going to go to a 15-minute break, after which we will continue with live sessions. So please be back at 11 Eastern Time. Thank you very much, and thank you to the panelists.
Thank you, Erika. Thanks, Marianne. Thanks, Dr.